Bismillahirrahmanirrahim. Our today's topic is a continuation of pulmonary lesion as a pulmonary mass. Whenever you see a density in the X-ray chest, I'm especially highlighting you about X-ray because this is a very elementary investigation you are used to face in the clinical practice and also in periphery everywhere that will have a black sheet of X-ray. So we are trying to make you to be oriented on X-ray first, later on there it is. And what is a density in the X-ray field? Asking you, is this a consolidation, a collapse, or a mass? And you have to answer these three things nicely. So let's have a review about the lesion seen in the X-ray chest, whether it's a consolidation, a collapse, or a mass. What about the consolidation? It produces a density with or without air program, and the lesion may or may not be bounded by fissure and may or may not following the segmental distributions. So a density to be seen in the X-ray film that has got no definite boundaries, and mostly there is no boundaries. Sometimes it would be defined by the fissure. And what is the next? There is the follow-up. You can have a later on that whether there is changes of the density or not, and there is really no obvious volume changes. This is very much important and may be associated with benign effusion. It is also part of our discussion today later on. And association of adenopathy sometimes whenever it has got any consolidation and due to inflammation. So the consolidation will have a diffuse distribution, will not produce any volumetric changes, will be associated with a benign effusion, and may be associated with adenopathies if there is an inflammatory association. And follow-up will make a part of changes in as part of therapeutic response. And you see, this is a consolidation seen in the left lab field. And whether this is a consolidation or not, you have to decide. The first thing is this lesion has got partially, there is bronchovascular markings seen in the lesion first. The second is there is no volume changes, means there is no mediastinal shifting. You see the trachea is an association and the patient has got some rotation and the mediastinum is mostly retained in its position. The CP angle is blunt somewhat, and this is a small effusion to be present, small effusion here. And what about collapse? There is usually, it follows segmental or lobe distribution. Usually deviates a functional anatomy as there is anatomical volume changes and thereby also lung volume changes depending on extent involvement hereby, and usually associated with mediastinal shifting because of the same reason and associated effusion or adenopathy as the underlying. So you will have a clean cut distribution of a segment or a lobe or a total lung in cases of collapse. It is having a definite anatomical distribution, not as in consolidation, which is really non-segmental. So it will follow a segment, a lobe, or a lung, and the collapse usually causes a local volumetric deletion really, so that there is deviation of the anatomy local, and thus there is visual changes, and these volumetric changes uh, causes there is reduction of the lung volume or lower volume as part of the extent of involvement, and there is mediastinal shifting and associated effusion as per the cause of collapse. So, a definitely anatomically precise involvement, mediastinal shifting, and volume changes is part of collapse. The collapse may be active, like in obstructive pathology, like malignancy or mucus plug, or a foreign body will cause collapse, executive collapse, and the passive collapse is the other pathologies in the pleural space that may causing the lack of expansion of the affected pulmonary areas, so that there is a passive collapse, and there are cicatrization collapse that is produced by the volume changes due to the destruction of the lung parenchyma and production of the fibrosis causes cicatrization collapse. These three things we usually used to get in common practice, so we have to know these things. Please feel what we are getting. Let's have a review. This lung has this is mostly opaque right lung seen here, and relatively clear left lung. The left lung you see, this is the large lung, is in comparison to the right one. The right lung is up from here down to here, you see, and the left lung is voluminous lung here to here, as the smaller right lung is also having the mediastinal structures, because the mediastinum is not at all seen here, so it is totally shifted into the right pulmonary density. So this is the right pulmonary collapse, also producing the gross tracheal shifting to the right side. There is some part of the right upper lobe to be containing air in this area, in the apical area, but most of the lung is basically open due to the production of the summation by the mediastinal shadow, and also the collapsed lung superimposed with consolidation. So this is the left large air space is basically a hyperinflated, which is compensatory to the collapsed right lung usually happens. So the right lung is totally collapsed with the gross mediastinal shifting to the right lung, and there is hyperinflation of the left lung seen in this chest X-ray. The left pulmonary collapse. You see that this is a right lung here, and this is left lung here. Left lung has got some whitish, some increased density. This whitish terminology is expressed in radiology as increased density. So increased densities are seen in the increased density areas are seen in the left lung. All the zones really. There is a diffuse increased density. Of course, there are differential densities used as a terminology to describe that the density is yes increased, but it is different at different places. So there is differential density consolidate densities seen in the left lung field. Even then, why I'm talking that this is a collapse, it looks like a consolidation. Even then, we are trying to talk about yes, this is collapsed left lung. Why? Because in this chest X-ray, there is a rightward rotation of the patient, because the clavicle on right side is away from the midline rather than of left side. So the mediastinum should be simply more to be located on right rather than on left, as a normal mediastinal structure and location. It deserves that the mediastinum should be rotated right side. But what is here seen that this patient has got a rightward rotation, even then the right heart border is merely seen along the right paraspinal region, so that even though the patient is rotated to the right side, the mediastinum is still on the left side, and the left heavy diaphragm is somewhat elevated than from the right side, and seems to have a small blunting of the left side angle. And on gross observation, you can see the right lung having an enlarged volume compared to the left. So this is really a total involvement of the collapse of the left lung. So this is the left pulmonary. There is an increased density seen at the right lower zone, and mediastinum is shifted to the right, and multiple channels seen in this patient. This is basically very acutely ill patient, and the density has got a temperature here reduced by short fissures here that is displaced upward from, and this is a right lower lobe collapse that that is that is skewing the right hemidiaphragm line and also part of the right heart border. This is the right heart border is really seen through the lesions. So this is away from the right heart border, and this is right lower lobe collapse. This patient also has got some consolidation in the right upper zone, and there is also area of reduced density, hypodensity. Some cavities are also noted here. So there are some multiple pathologies present in this patient. This is a right lower lobe collapse. There are some text informations described here as a direct and indirect signs of the collapse seen in the chest. So there is displacement of the fissures and crowding of the pulmonary vessels, are the direct sign of the collapse. The area involved also has got indirect signs like elevation of the ipsilateral hemidiaphragm. There is crowding of the ipsilateral ribs, the shifting of the mediastinum towards the side of the atelectasis, and the compensatory hyperinflation of normal lobes or even the contralateral lobe. There is hilar displacement towards the collapse. CT will give you a total causes and distribution of the collapse. So this is the important information you may have, that there would be displacement of the fissure and crowding of the affected area, pulmonary vessels, and all has been described, and I try to make you understand that whenever you get a shadow, whether this is a consolidation or a collapse, you can describe. And some important information you will get from the association of effusion in collapse or consolidation. The benign effusion is what there is fluid seen with proportionate contralateral deviation of the mediastinum. And this malignant effusion, there is no mediastinal deviation. The mediastinal deviation will be absent or very little regarding the amount of effusion present. So what is here? You see there is an effusion having a homogeneous density with concave upper margin is a benign effusion. Is an effusion seen in the left lung, and this is a benign effusion because there is no other abnormality seen other this effusion, like in no mass, no hilar enlargement seen, and the moderate effusion is not going to displace the mediastinum very much. This is a scenario of usually what we get in the pulmonary tuberculosis in our clinical practice. And this is benign effusion. You see that there is a large effusion causing the contralateral displacement of the mediastinum to the left. So the effusion causing the displacement of the mediastinum is a very typical sign of benign effusion. And what about the malignant effusion? You see, it is also density homogeneous here in the left lung. At this moderate effusion is still not displacing the mediastinum towards right. And additionally, there is a mass shadow seen around the left hilum. There is a large effusion here in the left lung, a mass in the left hilum, and no mediastinal shifting. The equation is malignant pleural effusion. This is also a large effusion seen in the right lung. You see that there is a mass shadow seen here along the right hilum, and the extent of the displacement is not that much to be as a benign effusion. and the topic I'm going to make you understand that from this effusion, how can I make a decision that this would be a benign cause or this would be a malignant cause? It means that there is an active collapse of the left lung previously present here, and the effusion here is producing a passive collapse here, and the mass, the active collapse, which would cause a local volumetric reduction, is really compensated by the positive pressure of the pleural fluid here. So the negotiation of the cooling effect of the active collapse is neutralized, at least mostly, to some extent at least, is by the positive pressure produced by the effusion in the pleural space. Thus how the malignant pleural effusion, however it is large, really does not produce any variational shifting in cases of X-ray, and thus whenever we get a large effusion without any mediastinal shifting, it denotes that there would be a presence of active collapse as a cause, and that would be a malignant effusion. And lastly, I need to go through another chapter, another part in association with the malignant benign effusion. This is biofluids. Sometimes we usually get effusion in association of tuberculosis mostly, and sometimes we get additional infection or the presence of the pyothorax from its early onset as an early onset. So how can I define a pyothorax from a benign effusion? The pyothorax usually produces an obtuse angle with a chest wall, whereas benign effusion, it causes blunting of the CP angle and the concave line. So the obtuse angle will be produced with the chest wall. It is unilateral or markedly asymmetrical, whereas the pleural effusions are usually bilateral and similar in size. Maybe bilateral and will be similar if there is a systemic cause of the pleural effusion. And it is markedly asymmetrical when it is bilateral. It is lenticular in shape, so that it is a biconvex figure in X-ray chest where there is a crescentic shape in cases of effusion, but this is a biconvex shape in cases of pyothorax. You see, this is a large, sharply defined margins are seen here in the left lung field. It is producing a biconvex figure and an obtuse angle in the chest wall. So this is whenever you get a biconvex lesion in the pleural space with an obtuse angle with the lung field. And this is a case of pyothorax. We get it also in ultrasound. What we get in ultrasound I should put a slide here. The next day I will describe you what is benign ultrasound. In clean cut benign ultrasound, we get just moving fluid in the chest, and in cases of pyothorax, we will get numerous running septa, and increased internal echoes in the fluid space that denotes the presence of excessive cellular tissues in the pleural fluid. And thus, the pyothorax is seen in the chest X-ray, and we can also be sure in ultrasound. These two important tools will give you to guide aspiration, because uh, whenever you will be a physician, a clinician, or radiologist outside the city and in periphery or in your chamber, you will get it. And these two tools will help you to aspirate, because these are the easily available methods, machineries you will get whenever you like. And the far away is the CT scan or MRI that is not easily available, and it's expensive in context of our economy. So this is all about today. Next day we will make another review of collapse, consolidation, and finally we'll give you an idea about a mass. So thank you very much for listening to me. If you have any question, you can connect me. Essential. I am here to answer you. Do you have any question? If you don't have any question, then we can switch off the session and we are going to leave it. Okay, thank you everyone.